era where knowledge can bring so much joy to the world, where knowledge can be earned from the tip of your fingertips. Pustaka Negeri Sarawak aims to provide that necessity to the people of the far and near, with facilities that is equipped with the up-to-date technology. Research and studies would be a breeze. Understanding the needs of the many, where knowledge seeking is crucial for the growth of the mind. We made it our ultimate goal to serve you the best knowledge center available. Outside our walls, we go and reach out to users and potential users in hard-to-reach areas. We'd go over and beyond by traveling to the suburbs to spread knowledge. To enlighten them through several knowledge activities via Pustaka's knowledge resources in our collection. Our responsibility to share latest technology and information. This way, we can ensure that the passion to seek knowledge never fades. It is our utmost mission to cater for and exceed the expected information needs of our users. For such noble cause, we study the profiles of our varied users to undermine their information requirements, get the needed information resources in whatever available formats, printed, non-print or online, and match them with the requirements. We take the extra miles of informing users about our rich information resources and tell them step by step how to identify, select, retrieve, and use these resources. We want our users to be literate in information and knowledge. We want them to be our knowledge beneficiaries. As our priority to preserve the knowledge and our heritage collections, we are committed to provide the user with access for those special and unique collections of Sarawak. With the facilities for storage and repositories, we ensure all the collections and public records which are more than 25 years old, and other documents, papers, instruments, statutes and statutory order, regulations or decrees, directed by State Secretary to be maintained, preserved and kept in the State Depository on account of their historical value or public importance. We are eager to expand by preserving the collections through legal deposits, donation, bequeath, oral history, and also transfer of public records for permanent preservation, regardless of its format and media. By creating standard bibliographic records, we will ensure the library resources or materials published in Sarawak can be accessed and will be preserved for future generations. We are going beyond boundaries in order to guide, advise and train all Sarawak government agencies with focus on the implementation of records and archives, management practices and standards thoroughly for Sarawak civil service. Researchers can use our facilities to do research on specific materials, whereby assistance is always available.
Having been here almost 20 over years as a user of Pustaka, it has been a very encouraging experience. Looking at the staff, how they operate this place, and for the past 20 years, this place is still in a very good shape, and it's even better now. So this is something that is very encouraging for us as users.
I think the best thing is that the library actually somehow in a small way that changed my life. First of all, I think the best is that I don't have to buy so many books. And then you don't have to search so far away, but you already can find it in the library. It makes my life easier. You can see, maybe you say reader is very confined to this, maybe very introvert, but actually the books make you more extrovert, meaning that you can actually connect with people better. Thank you very much, Pustaka Negeri Sarawak.
most importantly, the predictive modeling. Artificial intelligence can actually amplify our efforts in disease prediction, resource allocation, as well as health education. So with artificial intelligence, we are better equipped to address the root causes of health disparities and force to path towards a healthier and a more equitable world. So I'd like to draw your attention to this crucial depiction of digital health challenges and potential. You know, even in Europe, digital health also faces a myriad of challenges, ranging from the intricacies of setting up and also scaling health services to the pressing concerns of privacy, security, and also consent. And trust also remains a paramount in this domain, emphasizing the importance of the establishing, at the same time, maintaining transparent relationships. Although Malaysia ranks first in the best healthcare in world category of the Retirement Index, it is very essential to note that even with this top ranking, Malaysia still faces many challenges in its healthcare landscape. There are still much to be done to ensure consistent quality and accessibility of its all citizens. And as we move forward, it is very essential to recognize these challenges. And by sharing best practices and also collaborating, we lay the groundwork for a healthier global community. Yes, empowering underserved communities is a cornerstone of the Sustainable Developmental Goals. And the guiding principles, leave no one behind, is not just a slogan, but a beacon for creating an inclusive global society. I firmly believe that empowering underserved communities is a pivotal for global health equity. When we uplift these communities, we are not only addressing immediate health disparities, but we are also building a foundation for a healthier, more resilient future. And every individual, regardless of their background, deserves access to quality healthcare. And ensuring is not just a matter of justice, but it is a critical step towards achieving our health goals. I envision Malaysia, particularly on the low-income countries, where every individual, most importantly our children, possesses advanced digital health literacy. This is not just about using technology, but understanding how digital tools can be harnessed to improve one's health well-being. And A Bright Horizons is not just a title. It is a promise that by harnessing the digital era's tools, even in the remote corners of the world, we are paving the way for our children to be enlightened, to be informed, and also be empowered. So let's unite in this mission, ensuring every child, no matter where they are, must have an access to the knowledge and also the opportunities they deserve. Then as we stand on the crossroads of innovation in healthcare, our mission is very, very clear: to craft a future where technology is the heartbeat of global health. And tomorrow's digital health landscape won't just be about the machines and data, but it will be a symphony of human touch, amplified by digital precision. We're not merely integrating technology into healthcare, we are infusing humanity into technology. So the future is not just digital, it is personal, it is human, it is ours to shape. So let's embark on the transformative journey, united purpose and vision. And the future of health is digital. The future of digital is humans. However, we need to always remember that as we innovate or as we evolve, let's ensure our technologies are centered around human well-being and also inclusivity. Thank you so much, everyone. Now let's move on to another session. Before we dive in, a few housekeeping information. If you have any questions for our esteemed speakers, please type them into the chat box as they arise. And our dedicated secretariat team will gather all these informations, these questions for our Q&A sessions, which will take place after all these speakers are presented. Now, so we encourage everyone to turn on your camera if possible. So that would help to foster our more engaging and more interactive sessions when we can see one another. So let's begin with our first speaker. For that, I would like to call Mr. Edison to do the honors. Over to you, Edison. Thank you.
Thank you, Dr. Roy, for the insightful speech. So coming up next, ladies and gentlemen, setting up the tone for this first edition of Sustainable Sarawak webinar series is our first speaker, Dr. Stephen Chu. Dr. Stephen Chu is a fellow Australian Institute of Digital Health. He is a clinical information technician with 25 plus years of clinical experience in internal medicine and orthopedics, and more than 20 years in clinical informatics. He is one of the co-chair of the HL7 Patient Care Work Group since 2010 and co-lead international and national HL7 standard project, and one of the clinical leader in the HL7 Fast Healthcare Interoperability Resource Clinic in on FHIR initiative. He will be talking about digital health literacy uplift, addressing the needs of underserved community. Please give a warm welcome to Dr. Stephen Chu.
Thank you, Chair, for... Thank you, Chair, for the warm welcome. I am absolutely delighted and honored to be one of these guest speakers today at this very important webinar and sharing some of my thoughts with international leaders of the field. Just a quick question. Do you want me to drive the slide deck, or are you driving the slide deck?
Yes, Dr. Stephen, you can share your slides.
Okay, all right, that's good. Let me put the slide deck into presentation mode and then share it. Hang on. Am I able to share it? Am I sharing it, or hang on. Let me, okay, I have to share it first.
Yeah.
All right, you should be able to see my slide now.
Yes.
And I will put it in I'll put it in presentation mode. All right, so it's all,
yeah, we can see
good in terms of, yeah, okay, cool. All right, so again, thank you for the opportunity, and I am honored, and I am very delighted to be here to share some of my thoughts with our international colleagues. So when I was asked to make a presentation, I was scratching my head as to what exactly I would be less boring in the topic, which is can be very dry. So after a little bit of soul searching, I kind of thought that I will I will touch on a couple of topics which are probably relatively rarely visited, in the area of digital health and digital health literacy. So, so first of all, the presentation is being divided into three areas. One is looking at the current landscape of digital health investment, and what would be needed to continuously to drive the investment, given that there are signs after the COVID that the investment are beginning to come off its peak, and how digital health literacy would be important in one of the maintenance drivers to continuously drive digital health investment. And in associated with that, will be a concept about epistemic injustice in the context of health and digital health literacy. I would also like to focus on a couple of factors by highlighting that technology alone and education alone is inadequate. There are a whole lot of intersectional variables that would impact on digital health uptake and also digital health literacy. So to that end, I created a health and digital health literacy framework, which hopefully would shed a bit more useful light into how it can help improve digital health literacy. And then looking at some of the strategies to realize or put the framework into implementation, including things like how does game theory contribute to the improvement, how does AI intelligent agents can be used, and finally, how does putting a human touch to the digital health literacy landscape can create more drive and efficiency in the uplift, and then round up with a roadmap at a glance, putting those variables together. So we know that COVID sees the peak of the digital health technology investment, and there are signs that the investment is beginning to soften, and that raises a question as to what are the factors that will be required to sustain the investment, if not lift it in a continuous upward trajectory. So when we work in the area of digital health, we always want to ask the question: if you are in a commercial world, what is the return on of your investment? And if you are in the government sector, you always want to ask the question: what are the benefit realization? How can you realize the benefit of the investment? So I've done a bit of discussions with a number of people over the years about benefit realization, and there are three areas. One is adoption, the other one is service delivery, improvement of service delivery, and the third one is providing systemic benefits. So I don't have time to go into all of them, but I would just highlight one, which is tightly associated with the concept of literacy, which is adoption. So in this landscape of adoption, what we'll be looking at is the healthcare democratization, which will be a condition where the consumers of the healthcare services would be able to use digital technology in gathering the information, sharing the information, and use the health-related information to improve access and use of the healthcare services, and also improve their health outcome. Now, if that's the one of the hallmark of benefits of digital health, then it follows naturally that for the citizens to be able to fully utilize the digital health, the benefits of the digital health technology, then their capability, their confidence, and their efficiency and effectiveness of using the digital technology would be very important. And you can see that from some of the reports, like the Digital Citizens report that is published about on a survey of the Australian citizens. The report highlighted the citizens want better access to digital services, and one of the top digital services that the citizen would be accessing will be health services, and they also want to be digitally equipped. So that all points back to the directions of they need to be have better digital health literacy in order to be able to realize those benefits. Now, but digital health, the landscape itself is actually quite challenging to navigate. There is a saying that healthcare system, in particularly healthcare system in the US, but I think it is also true to other parts of the world, that the healthcare system is incredibly bureaucratic, difficult to navigate, and alienating to the consumers. And digital health is not that very different. So they are quite difficult. I mean, technologies are not necessarily that easy to use. Technology becomes more and more complex these days. Even consumer digital technologies, one probably would need to be very skilled even in setting up your smart TV at home, let alone sort of navigating the field of digital health. So there are challenges, like, say, for example, how and where do I find the information? When I find the information, can the information be trusted? And what about security risk? So the challenges are actually making digital health utilization even more difficult. And there is a very important saying that success in digital health will not happen by just having the best technology alone, even if you have the best technology. Everyone has an Apple Watch or a smartwatch that can monitor your heart rate, but that doesn't mean that you are digital health capable. So so therefore, all this also points back to you need the citizens to be competent, confident, and effective and efficient in the use of the technology. And that's all sort of comes back to the questions of literacy. So if we accept that literacy is an important component to sort of benefit realization, and that knowledge and literacy is about knowledge, capability, confidence, then and that it is a human right. So if we accept that premise, then it's kind of like generates a question of does this human right impose an obligation on society? So therefore, a society has the obligation to educate its citizens to become health and also digital health competent. And at the MedInfo 23 conference, one speaker talked of the concept of epistemic injustice, and he said that he made the claim and say that not educating citizens for basic literacy in 21st century is a society that commits epistemic injustice. So that's a very interesting argument. I would sort of expand on that a little bit later. But first of all, there are a couple of definitions for or the types of epistemic injustice and types and also definitions. I don't want to go into a lot of details. Suffice to say that it's all focused on a knowledge gap, and because of the knowledge gap and also the distrust or discrediting healthcare consumers as unreliable informant of their own illness or experiences. So the concept of patient-centered care and patients in the driver's seats of their in control of their healthcare destiny becomes almost impossible. And so therefore, the problem of epistemic injustice should be addressed. There's no questions about that. But the question is about how much education is actually enough if we accept that we need to address epistemic injustice by using education as a mechanism. So I actually had a bit of a sidebar discussion with the speaker and said that, look, I totally agree with your comment about digital health or health literacy is important, and not educating citizens would be equivalent to committing epistemic injustice to the society. But how much education is actually enough for the healthcare consumer? So I cited two examples. On the left-hand side of the slide deck, I have given two examples. One example is a real-life example of an MRI examinations of a report of a patient who suffers from primary CNS lymphoma, and the information is so complex. Even me with medical training, not in the area of neurology, sort of have difficult looking at this report itself to sort of make a very sort of authoritative clinical judgment and decision about it. So I have to talk to the patient's radiologists and the patient's hematologists and neurologists and review the patient's medical information to be able to understand and interpret this piece of MRI report. So addressing epistemic injustice is not that simple. So you can't just go and give every citizen 20 years of medical training or IT training to make them literate to the degree that they can navigate the complex world by themselves. And the bottom of the left-hand screen is a screenshot of a very simple health interoperable standard design. And just even sort of looking at the body site, which is a codable concept, that means that you can put a simple code to say that, look, this is the body site that has a certain kind of pathology if you're looking at a histopathology report. But the problem is that in the domain of cancer, say, for example, if you're looking at sort of small cells carcinoma, there are sort of types of carcinoma that have combinations of small cells or mixed morphological findings that are affecting multiple body sites. How do you then sort of support that kind of representation in a digital format, and yet not causing sort of confusions to the implementers and not causing confusions to the reader? So those are a couple of those are two of the many examples that I have. So to illustrate that addressing epistemic injustice is not just simply about education. We have to do better than that because society doesn't have the resources to train everyone to be an IT specialist, to train everyone to be a clinical specialist. So then it begs the questions of so how do you then address sort of this kind of complex problem? So I have a lot of thought about what actually does digital health literacy mean? Is if it's not just about education. So I went down the rabbit hole of decomposing the components of digital health literacy, and look at what digital health literacy this concept is built on. So first of all, when I do the decomposition, I sort of come to the realization that for you to be able to navigate this digital health information, you have to have certain degree of health literacy. And you have to have certain degree of media literacy. Why media literacy? Because today's world, there are a lot of misinformation that are being published in the social media. If you don't have the certain level of media literacy, then you won't be able to make sort of like have the ability to differentiate what I call the good, the bad, and the ugly. And so you need that level of literacy, and you need the digital technology literacy for you to be able to master the application, master the technology to be able to help you to do the navigation. So that's the next tier that digital health literacy is built on. And health literacy, media literacy, and digital technology literacy is built on top of another layer, which sort of include what I call the intersectional layer, where there are multiple factors that intersect with each other to provide compounding effect on the individual. So the social determinants, the culture, the person's health belief, and also the digital inclusiveness. So all those factors interact sort of like to impact on how a person can understand the health information, or is willing, even willing to understand the health information, and willing to understand and use the technology to rise to the level of digital health literate. So with that in mind, so if I were to design any digital health literacy uplift strategies and policies and roadmap, I would have to consider all those three layers of interacting or intersectional factors or variables for the uplifting strategies and program to be successful. So having looked into the framework, then the question is that if we accept the fact that we can sort of like train everyone to be an expert in every area, then what can we do to make the education as broad as possible and as deep as we can afford? And so are there any innovations that we can think about? So in the covering slide, I put out a statement and say that, look, necessity is the mother of creation or invention or innovation. So if we need something that is truly innovative to make digital health literacy uplift to be as broad and as possible and as tailorable as possible in terms of depth, then we need to look at something innovative. The games theory, using games theory to develop interactive educational games would be some very useful things to consider. And using intelligent learning agents would be something that would be very useful. And then there is always a need for digital health navigators, which I will touch on a bit later on. And so therefore a blended approach of the technology and the human touch would make it sort of relatively effective. So that sort of leads me to investigate what kind of games of sort of theories and also games simulations would be sort of most effective. When I was working in New Zealand as an associate professor for the University of Auckland, I led a project, a couple of projects which uses sort of games theories to design games for patients' rehabilitation, and they work quite well. So the lessons that I learned from there is that for the games to be accepted and used by the patient or by the learners, they have to be meaningful, relatable, experiential, captivating, fun, and interactive. So if we sort of take those principles and the requirements to consideration, and then put them into a certain sort of type of games, that will be very useful. And I actually came across a presentation at MedInfo 23 in Sydney in July. One of the presenters actually sort of quite interestingly sort of present as a set of digital interactive games sort of based on the Squid game. So for those of you who are familiar with the Korean Squid game, so you would be familiar with that. The game sort of capitalize on dividing the participants or the players into two groups. One group is the good guy, the other group is the bad guy, and then the story is being written sort of along the good guy trying to beat in the games the bad guys, and the bad guys try to block the good guys from advancing. So it's actually quite an interesting sort of idea in competitive games that principle that can be woven into the digital health education, and sort of to provide the interactive, relatable, experiential, and fun-filled type of activities, and appeal to the human nature that I want to win, I don't want to lose, that kind of mindset. So this slides kind of look at
yang mewujudkan sikit proses untuk.
Sorry, is my time? Am I over time?
No, you are on track, Dr. Chu.
Okay, so if you look at the framework that I highlighted a few slides ago, so you can look at those frameworks, the variables in those frameworks, and you can then put those sort of frameworks into either the promotion zone or the offensive zone or the defensive zone. So you weave the stories and put the stories into different zones, and so therefore and you require the protagonist and the antagonist to be crossing into the different zones, and so therefore defend or attack sort of your opponents sort of based on those variables, and in that way, so the people who are being assigned those characters has an incentive for wanting to win and play with those variables, and hopefully they will be able to sort of learn from the lessons of playing those variables, and to put those things into perspectives, this table sort of separates sort of a number of digital health enablers type of variables or factors. So from base sort of from technology to language to competence to information access to information reliability, psychological factors, cultural factors, privacy, confidentiality, security factors, and you can have the barrier side and also the facilitator side, and you can then look at how do you then weave those variables into a story and build a story script that would allow the protagonist to enhance the strength of the facilitating factors, and the antagonists would try to put up barriers, sort of and would teach the protagonists how to use the facilitating variables to overcome the barriers. In that way, so you can build an education program which is quite useful. And actually, sort of, you can. I mean, I know that universities today are beginning to use the discrete theory. So in the economics lectures. So I did a Google Monash University, my alumni university. Sort of actually their economics faculty actually uses discrete theories as game to create games to teach students about economics, which is actually quite interesting. So games alone probably is not going to be sufficient. So as I said, technology is actually quite, a lot of the technology is actually quite difficult to navigate and also to organize. So this is where smart agents or intelligence agents can help. So we can create some personalized intelligent agents that sort of understand the person's preferences, social characteristics, and learning and interaction styles. And those knowledge that are learned by the personalized intelligence agents can then be fed into the games agents. And they can be fed into the protagonist agents representing the person playing the game, and sort of make sure that you would sort of create a profile that can be sort of assisting the learner to try its best to overcome the antagonists. And then you have language agents who can be used to overcome language barriers. And we know that a lot of if we are going to use sort of international, customized international learning material, a lot of the learning materials are being written in English for people who comes from English as a second language or low English competency community, like sort of linguistic and cultural diverse community. A language agent can be very helpful. And then you have tutorial agents, digital secretariat agent. And so you have a set of games agents to be able to sort of use sort of to play against the learner. You can the learner and the games agents can swap antagonist and also protagonist role. And having them play the antagonist role is also educational in helping them to understand so how bad things can happen and how to avoid them, that kind of thing. So I find it quite interesting, sort of in that regard. And then we'll look at sort of technology can actually be quite alienating and difficult to navigate. Having a human navigator to provide a bit of hand-holding to people who are less digitally capable will be a very important and useful strategy to use. And it's useful to alleviate the fear and also provide the much needed psychological support, telling them that you're not alone in this journey, and you can be you have me to be walking the journey with you, holding your hand if necessary, and providing the technical support. And there are sufficient international research in the other area, like the patient navigators in the healthcare system, that helps the patients sort of provide the confidence that to the patients in navigating the very foreign or bureaucratic, unfriendly healthcare system. So in closing, you can the framework can be instantiated in this roadmap. So in particularly in the area of meaningful co-design, you can taking into considerations those intersectional variables or factors, you can then sort of incorporate people from the indigenous community, cultural and linguistically diverse communities into co-designing something that is meaningful and useful to the education program. I had the experience of having a conversation with a number of our indigenous community elders. We call them uncles. So a few of those uncles were talking about how the healthcare systems that are being created by the white government are not suitable for their requirements. So I sat down with them and asked them a whole set of questions as to if they were to design a healthcare systems or policy or strategies for their community, what do they think would be important and useful to be incorporated? And they gave me a list. So that experiences kind of makes me wake up to the degree that if we were to design some educational program for the underserved community, then bringing them along the journey in co-designing the literacy uplifting program will be absolutely important. And then the scope has to be realistic, has to be patient-centric and innovative in order to make sure that it capture the imaginations of the people who will be using the technology, using the uplifting program, and then you then look at how do you address the barriers. So if you look at the bottom tier of the framework that I have created, the bottom tier of the intersectional variables actually highlights a lot of barriers. So those barriers needs to be addressed. And if you are able to co-design with the target population and addressing those barriers, then you will go a long way to creating a very useful, meaningful, and experiential contents, and using technology to help them to realize the digital health literacy that would need to help them to navigate the system. So I think with that, I come to the end of my presentation. Thank you.
Thank you, Stephen, for that presentation. Now we proceed to our second presenter, Dr. Anand Kisha from Christiania University College, Norway. Anand Kisha is a professor of health policy and economics at Health Science and has extensive global health policy research experience with a focus on health and economic development, use of health services, comparative health system, cause of illness, cost effectiveness of intervention in the healthcare system, and research on health outcome. Dr. Kisha has more than 100 peer-reviewed published articles, books, book chapter, research report in health policy and economics, and he is a member of many international health institutions, scientific boards, and editorial boards. Dr. Kisha was the principal investigator for the Turkish National Burden of Disease Cost Effectiveness Project financed by the World Bank. And he is the curator of the Institute of the Health Metrics and Evaluation of UW Seattle, USA, the WHO Innovative Care for Chronic Condition Project, WHO Adherent to Long-Term Therapies Project, WHO Health Survey and Value for Vaccination Research Network at the Harvard University. Dr. Kisha has received many awards and recognition related to teaching, research, and service throughout his career. Dr. Kisha also holds adjunct professorship at Tulane University and University of South Carolina. Presenting paper on digital health economics, Norway path to viability. Please welcome Dr. Kisha, Dr. Anand Kisha.
Oh, thank you very much for this nice introduction. Good afternoon to all participants. Before I start my presentation, I'd like to thank you. I want to thank all of organizers of this wonderful activity, and also Dr. Roy. He was the leading person. And thank you very much for kind invitation. We have 6 hours time difference between 2 countries, but this is almost 9:30 around here. So not very early. This is the good part. I woke up. And today I will share Norway's experience regarding digital health economics. So I can use the screen, I think, or we can continue like that. No problem for me. Okay. Norway is located a little bit out of the European continent. You can easily see we have really large. The country is located on a large area. The population is almost 5.5 million people, and 18% of the population live in rural area. So which means still, even though 82% of the people live in urban areas, but the distance between the cities are very far. So the importance of using digital health platforms we can see in here. The per capita income is very high, so it is among the top 10 wealthy countries, I can say. Next slide, please. Very quick introduction to the Norwegian healthcare system. It is completely tax-funded healthcare system, and decentralized public governance structure we can see. The government owns almost the majority of the health system, especially the system is very strong in terms of primary care delivery. So by using primary care services, people can easily access to general practitioners, and general practitioners are the gatekeeper of the system. Next slide, please. If you look at the map in here, you can see that the majority of the people are located in big cities like Oslo, like Agder, Bergen, and also in Trondheim. So even though the country is 5.5 million population, the majority of the population are located in the bigger cities. Next, please. You can see a comparative table in here regarding the socioeconomic and health characteristics of the countries. This is based on 2019 data. There is not big difference. But when you compare with the other Nordic countries versus US, it's a completely different system. Life expectancy of Norway is very high. And when you look at the child mortality and also under 1 and under 5 mortality rates, the Nordic countries are performing very well compared to US, for example, in here. But the health expenditures is around $8,500, and it will be by 2050. It will be more than $10,000, which means the health expenditures are going up. Yeah, next, please. Of course, health inputs are very important, especially we are talking about health literacy, we are talking about digital health. So when we look at the physicians per 1,000, nurses and midwives per 1,000 population, and hospital beds per 1,000 population, Norway is not having enough number of physicians in terms of per 1,000 people compared to other neighboring countries, Nordic countries. And the number of nurses and midwives are so far looks okay, but we need more nurses. And hospital beds per 1,000 population are around 5 per 1,000 population, which means still we need more hospital beds. But of course, running a hospital is a costly intervention. So the government is controlling the hospital system in Norway. This table is very interesting because it is showing the top 10 causes of death in Norway and also other surrounding countries. I also compare with US and Canada to give you some kind of information. What we see in here, we see the majority of the leading causes of death in Norway are the chronic diseases, mostly ischemic heart diseases, stroke, Alzheimer, lung cancers, and all type of other cancers like colorectal cancer, prostate cancer, and pancreatic cancer are the leading cause of death in here. And these major chronic diseases are forcing the health system to find cost-effective interventions to reduce this burden. But if you compare with the other surrounding countries, the US and Canada, there is not much difference. So the majority of the diseases we can also see among the top 10 over there. So ischemic heart diseases and cancers are the leading cause of death in all countries. Please, next, please. I don't want to go and talk too much about the Norwegian healthcare system, but in here it is important to note that under the roof of Ministry of Health and Care Services, we have a Directorate of e-health, specifically focusing on digital health and e-health related activities in here. And it was established in 2016, and it implements the national policy on health, and also sets up some kind of national standards, and also try to adopt internationally developed standards for the national use. And also the Directorate administers the use of e-health methodology nationwide. So there is a governing body and who is responsible running the e-health related activities in this country. Of course, not only acting alone, this directorate is also collaborating with the other ministries in Norway. Next, please. The Department of Health, again, they coordinate the healthcare digitalization in this country, manage the health data and digital security, because digital security is very important. Therefore, for example, they need to collaborate with the Ministry of IT in this country, because the digital security is one of the major issues that we need to discuss, especially when we talk about digital health in here. They also develop national framework conditions for the digital solutions. When we look at their focus areas, they focus on digital healthcare interaction, digital services for citizens and healthcare providers. Health data management is also another focus area. Digital security and privacy, ICT infrastructure, and international e-health cooperation are the responsibilities of the Department of e-health. Next, please. When we look at the notable services of this directorate and also impact, of course, impact is very big. There is a really good digital health platform called Helse Norge, which means Health Norway. And this platform is very useful platform. I will give you more information about this. And these notable services are also digital communication between citizens and healthcare providers. E-prescription is very important, because without going and seeing your GP, you can renew your medicine. And they also participate to European health data space. When we look at the impact of these e-health services under the leadership of this directorate, we can see that improved healthcare efficiency, enhanced data security and privacy. We see that more empowered patients through digital access, streamlined medication management, and also facilitation of international health collaborations we can see as any impact. Next, please. I also, for the purpose of this meeting, I also checked the national e-health strategy of Norway, and it is for the years of 2020 and 2030. Between these three main goals, they like to achieve quality and coherence in the services, sustainable health and care sector, and innovation strength in here. And they have 5 detailed strategic objectives to achieve those overall goals. One of them is active participation in own and close one's health, easier working day, health data for renewal and improvement, available information and collaboration, and also cooperation and instruments that strengthen implementation. Yeah, at the end of my presentation, I also provided the detailed links for those reports if you'd like to see more detail about the Norway's experience, you can go and look at this national e-health strategy in English. Next, please. So when I look at the all e-health strategy and look at how they are aligned with the Sustainable Development Goals, Sustainable Development Goal 3, 10, 12, 13, and 17 are directly and indirectly related to those overall goals of this national e-health strategy in Norway. Next, please. Of course, when we talk about the economic side of digital health and digital health literacy, we know that if we use a good e-health infrastructure in a country, we can have cost reductions at all categories. One of them is travel cost reduction. So less frequent time to travel from healthcare facilities to homes. If, for example, if you are living in a rural area, of course, remote monitoring tools, mobile health applications, and telemedicine are wonderful e-health interventions that we can wisely use. The other one is infrastructure optimization, which means e-health reduces the need for expensive physical health infrastructures by digitalizing services. So you don't need to invest more for the physical infrastructure more. And there are also cost-effective resource distributions and overcoming geographical barriers in rural areas that we can see under the category of infrastructure optimization. And using more the e-health initiatives also lower the hospital admissions, and also which means you save money to improve the health of the population in all countries. For example, it is saved amount because unnecessary hospital admissions, and also savings because unnecessary hospital admissions and visits will create you more opportunity to invest in other parts of the health system. Next, please. When we look at the indirect economic advantages of e-health, we have decreased work absenteeism because fewer absences due to in-person health appointments or prolonged hospital stays we can see. And enhanced productivity we can see. For example, e-health accessibility saves time, promote work-life balance, and especially for the working class in secluded regions. And it can also increase the quality of the life. So improved health management via wearable tech, health applications, and online resources can help us to increase the quality of life because we are getting different health intervention to see the benefits, which means we can also reduce the stress due to easier access to healthcare and health information. So these are the indirect economic advantages of e-health. Please, next, please. Okay, this is one of the health platforms that we use in here. One of them is DIPS, electronic patient profile. It is used by the 80% of the Norwegian hospitals in here, and more than 100,000 health professionals uses this in Norway, and 4.3 million patients have access to these journals, so their journals. And if we look at the efficiency, increase overall operational efficiency by 30%, and they have annual saving of more than 20 million kroner we have by using these electronic patients. The objective of this system is to provide a unified digital health record system for efficient patient care. It is directly associated with the Sustainable Development 3, good health and well-being. When we look at how the system, this platform, have impact on the vulnerable population, it ensures that consistent and error-free health record access is provided because of this electronic patient journal. Please continue for next slide. The other one is Helse Norge, the national health portal. This is used by almost all people. So you can easily access your health information, renew your prescriptions, and communicate with the healthcare services. There are also some live and live chat boxes over there. And also, if you need more information, you can find guidance from the system. More than 2 million Norwegians actively use that system. If you look at the economic impact, reduced administrative overheads by streamlining the patient-hospital interactions, we can see in here. And it centralizes health services, information, and patient communication on a single platform. It is directly linked to good health and well-being, number 3 of Sustainable Development Goals, and number 9, industry, innovation, and infrastructure. When we look at the benefits to vulnerable population, the system offers a centralized platform for those in remote areas. Next, please. Another one is Yarne Journal. It's called Shared Health Record. It's a digital platform, national health system that shares health data across the health services. It provides healthcare professionals with fast access to key health information, especially in acute situations. It has medical conditions, vaccinations, donor card, medicines, test results, documents, and appointment history. And it is available to hospitals, general practitioners, out-of-hours medical services, and also municipal nursing care services. And patients can limit their access if they want and block certain professionals or receive notifications on data access. So they have a control over this shared health record. Next, please. And if when we look at the results, many medical record errors are reduced. There is an enhanced data accessibility for healthcare professionals. So when we look at the major economic impact, the system is reducing repeat tests in here. Minimum 10 million kroner annually we save by using this system. It is directly associated with the Sustainable Development Goal. When we look at the benefit to vulnerable population, the system is prevention of medical errors for patients with multiple conditions. So it's running. It's a good running system that I can say. Next, please. Of course, telemedicine is one of the best intervention that many countries use. Turkey, telemedicine is widely used in Norway. Norway is one of the first countries implemented telemedicine-related intervention. They started to implement the Norwegian government has started to implement the telemedicine initiatives in 1990. And we have 4 regions, and these regional authorities operate multiple hospitals aiming to provide equitable healthcare access in here. So telemedicine is widely used by these regional authorities also. When we look at the geographical distribution of the people, and the country is very big, so we have really big, most sparsely populated population in here. So mainly residents in remote areas with limited access to traditional medical services use telemedicine in Norway. Next, please. There's an initiative called Norwegian Telemedicine Initiative. Rural areas of Norway, especially in the north, it is widely, they have different interventions. They reduce need for patient transportation, timely medical consultation. When we look at the economic impact rate, they have reduced, the system has reduced travel-associated costs for patients and healthcare providers. And when we look at the Sustainable Development Goals, it is directly related to the Sustainable Development number 3 and 10. And when we look at the benefit to vulnerable populations, the system enables those in rural and underserved areas to receive timely consultations. Next, please. If you look at the adoption rate, 100% at the regional level, 75% at the hospital level, and 21 out of 28 hospitals actively use telemedicine, and the usage has increased, especially neurosurgery, rehabilitation care are widely used, but we can see that the telemedicine is also used for cardiovascular diseases and also diabetes treatment. And also you can also have the digital dialogue with your general practitioner by using this system. Next, please. There is a really good running prescription system. So it's a nationwide, and 90% of all prescriptions in Norway are now electronic. And it reduces paperwork, fever medication errors, and an estimated annual saving of more than 15 million Norwegian kroner. And it is directly associated with the Sustainable Development Goal and streamlines medication management for elderly patients in remote areas. So this is a wonderful system. So these elderly people and vulnerable population don't need to move physically to get their prescription. So when we talk about the direct economic impact, indirect economic impact, and societal impact, I studied those impacts under the categories of these digital health platforms. Of course, many of them are related to reducing duplications of medical tests, reducing administrative costs, less paperwork, elimination of the costs associated with the paper-based prescription system. Those are the direct economic impact. Of course, enhanced coordination among care workers, increased health literacy, and more trained health manpower are the indirect economic impact in here. But overall, when we look at the societal impact of those digital health platforms, what we see that a good monitoring system is it's a good monitoring system. It is working very well, and also people can easily share data. Of course, these people are health professionals, and sharing data, getting better information about the patients and the people can lead to better population health management in Norway. Next, please. In terms of health literacy and sustainable development goals, the system recognizes the unique needs of vulnerable population in relation to digital health literacy and explores strategies for promoting digital health literacy among underserved communities and assess the potential impact of inclusive digital health literacy initiatives on sustainable development goals. So these are the three main things that I can talk about, these 5 e-health or digital health platforms. So these are the more centralized platforms for health information for the patients, eliminate the geographical barriers for the people, and also a good prescription system also help them to use efficient use of medicines, and also patient-related health information are widely shared among the health professionals from primary care level to up to tertiary care level. So all of them are having direct impact on improving the health literacy level of the people in Norway. Next, please. By 2025, Norway aims to have 95% of its elderly population to use digital tools for health. A lot of direct cost savings from reduced hospitals visits. We can see 25% of reduction in costs associated with the patient, for example, living in one of the less populated area in Finnmark, for example. 94% of all prescriptions are e-prescriptions. 96% of the municipalities send electronic referrals to hospitals. Telemedicine is widely used to improve access to care and provide continuous education. And also, in very sparsely populated areas, pre-hospital emergency services are provided within the municipal home nursing facilities with the support of telemedicine. These are the some facts that I highlighted for the participants of the conference today. Next, please. Some examples, these are the final slides. For example, chronic disease management, we have digital platforms like My Health platform. It reduces 20% of the reduction in hospital admissions for chronic disease patients. For the mental health related service, there is an example platform called Health Talks. It reduces 15% of more patients treated with the same resources and saves a lot of amounts of money annually when we run these digital platforms. So people feel more convenient. to reach out and also use these sample services in here. Next, please. In conclusion, when we look at the Norway's pioneering approach, digital health initiatives as a kind of benchmark of cost effectiveness. When we talk about the universal accessibility, technology is a key. When we talk about the efficient health outcomes, of course, technology improves the health results of the population and has a great impact on mortality and morbidity and life expectancy and life quality of the people. It's a sustainable model. It's an innovative model. So we live in a Scandinavian area and Nordic area. So the countries are also sharing their experience to each other. It's a kind of good innovation to share and learn from other countries. And it's a kind of the standards that we have in this country regarding digital health follows the international suggestions. And the final and important part is empowering vulnerable population, because when we prioritize the digital health to bridge the healthcare gap for rural and vulnerable population, it is really a good tool and cost-effective tool to reach those people living in rural areas, and those people don't have enough time or work time or opportunity to reach their healthcare provider. It's a good option, and it's a cost-effective intervention, I can say. Next, please. Next, please. Thank you very much for this wonderful opportunity. I share some Norwegian experience, so very practical applications I share. You can see some views from Norway in here. At the end of this session, I know that there will be some questions from the audience. So thank you again for listening.
Great sharing, Dr. Anantisha. Thank you so much for that. Now we are to our third topic for this session, talking about AI solution and digital health. How do they influence equity issues? By Dr. Sarah Wamala Anderson. She is a professor of health and welfare technology at Mälardalen University, Sweden. Sarah is the former Director General of Swedish National Institute of Public Health and has previously served as Professor of Health Policy and Management, Karolinska Institute. Let's welcome Dr. Sarah Wamala Anderson.
Hello, Sarah. Sarah, I think you're muted.
Oh, thank you. That's the classical one. Thank you so much. I am so pleased to be here, and I would like to have this opportunity that we connect with ourselves. If we just take a few seconds just to close our eyes and just feel that we are in this digital space together. Okay, please, let's go ahead and you breathe from the stomach, of course. Thank you. Thank you very much. Now we are here. We have closed everything else that is going on. I would like to thank you very much. I really feel so pleased when you reached out, my friend, Dr. Roy Mazo, and working together with your awesome colleague, Dr. Edson. What you have done is incredible. Thank you very much for bringing us all together to have this conference. I listened to a few speakers before, and it was really high quality. I learned so much. Thank you very much for bridging the gap, because what we are going to see in the world now is the knowledge gap between different parts of the world. Last week, I was in South Africa at the University of Johannesburg, and we're talking about how do we create student mobility and staff mobility to reduce the knowledge gap between continents. So what you are doing, Dr. Loy and Dr. Edson, is exactly that. How do we use whatever we have from where we are to reduce that gap. Because if we don't do that, we'll be facing a lot of challenges. Now we are talking about digitalization, digital health technologies, artificial intelligence. But below that, we need a lot of knowledge at different levels, at the scientific level, at decision makers level, at citizen level, at professional level. So we need to link all those levels to make sure that we are talking about the same thing. And we also know that how can we get the best out of the technologies now that are booming. So thank you very much for doing that. I have learned from my previous presentations that what if you tried to have a presentation without a PowerPoint? So I said, I'm gonna give this a shot today and let's see how this will move. And what I like about it actually, when you don't have a PowerPoint, so if you have any question at all, I feel like it becomes like a conversation. So when you feel that there is something you want to talk about, so let's have a conversation. And that's what I'm looking for. I believe that everybody who is in this digital space here, they have a lot of knowledge, a lot of perspectives on different things. I'm always keen to learn from others because like today, I learned so much and I feel so grateful. And I hope we continue to do that. So I was asked to talk about artificial intelligence solutions and how we are doing in Sweden. I would say that there is so much going on, and I would like us to, first of all, to think about that we are living in a wonderful time in the history of the world. So we have to remember that because there is so much going on. I would like to highlight a few mechanisms that are going on in the world. Digitalization, new type of globalization, internationalization, and the new geopolitical tensions that are going on. So we should try to understand that space that is going on around us, and then try to see how do we get the best value of artificial intelligence and digital health technologies, and all technologies that can actually enhance humanity and socioeconomic development, because that's where I want to go. And I like that Dr. Roy is very keen on talking about the Sustainable Development Goals. And I think that's really very, very important, because if we don't think about that, it will be very difficult to make an impact. I would like to highlight the fact that I think every region, every country now, the new competition, the new goal, as some of my colleagues say, is going to be about data. And that's why the artificial intelligence now comes in much more. And of course, we need to understand the algorithms. Without data, there is no AI. So I think we need to go back to the data and where that data is being generated and what kind of data are we looking at and what is it going to do once we get them into those algorithms. So I'd like to discuss a little bit on that. But going back on what is happening in the world, we know that I looked at the new prognosis. It was interesting to see that by the year 2050, 40% of the global population will be at 75 years and above. And also we have a lot of prognostic data showing that there is a possibility that humans will live 120 to 150 years. And I would like to bring in those perspectives to try to understand, okay, what do we want to do with the AI given that trend? But on the other hand, and remember the 14% I talked about 75 years plus, if we compare to the 1950, it was only 1%. So that gives a feeling of how the population dynamics is going to look like, right? At the same time, when you look at the young people, 0 to 19 years, so we see a downgoing trend that we are going to have a lower proportion of young people. So what gap are we talking about now? And when you look at different regions, like I was on the African region last week, so you find that 70% of the population, they are 30 years 30 and below years old. And now when we look at Europe, my colleague from Norway was talking about the growing, increasing elderly population, which is similar to all Nordic countries, many European countries, Japan, China is facing that. So what does that say? So I'd like to bring in those perspectives. And in addition to that, we see that there is a trend of growing care costs. For instance, in Sweden, we put 10% of our GDP on healthcare, but only 3% on prevention. Yet we know, as previous speakers talked about, that we have an increasing prevalence of chronic diseases that could be prevented. And I know many of you who are from the public health background, then we are thinking about why are we not investing in health promotion, in prevention? Yet we have the technologies that can do that for us. I think it's going to be a very interesting dynamic now when we talk about technologies and we are talking about healthcare costs and we are talking about the deficits in health workers and having a large proportion of older people. And by the way, that we now see the increasing life expectancy. But the problem is we find that many of the older people actually live 10 to 30 years with ill health that could be prevented. So which means that translates into healthcare costs, society costs, and also suffering of the people involved in that. We just had a new report. We have something called the Swedish Internet Foundation. So they wanted to see what people think about AI and what types of AI is being used a lot in Sweden. It was interesting that 25% of the Swedish people now, they at least use a ChatGPT. It's very interesting. Now I'm thinking about my friend, my colleague who talked before, Dr. Chu, talking about the digital health literacy. And I really loved the way Dr. Chu, you described it very well. I'm looking forward to discussing more because you said something that if it doesn't matter how good the technologies we have, but if people don't understand them, how to use them, then we won't move anything forward. And also, of course, the digital health literacy, as you talked about, is not only that the citizens, the patients, the individuals using them, but we also have them in different levels in society, the health professionals, the decision makers, we have a big issue there, politicians, they need to know more about, if we talk about AI, what are we talking about? This report also showed that 30% of the Swedes think that AI is going to have a negative influence in the future. So what does that say? So there is lack of trust around the AI. And it was also mixed because 36% also said that the AI could have a positive influence in the future. So we have a divide that some people think that AI is very good, others think it's not really good. And then we have in between, think about the normal curve to these sides, and then in between those who think that we don't know, could be positive, could be negative. So what does that mean in terms of our research agenda? That we need to provide more evidence to show the effects of AI from different perspectives, but also to show the potential risks and how could those be actually revised, because it's really possible to do that. It's not, I usually refer to the pharmaceutical industry where I had the opportunity to work there. So if you have a pill and then you have done these clinical trials, beautiful ones, and then you show that this pill is not more beneficial compared to the placebo, then you have to go back to square one. But with technology, you can still change certain things. And when we talk about AI, then you have to go back to the data and then change those data, rewrite the algorithms and make things right. So we have a beautiful trend there which can be done less costly and actually very time effective. But when we talk about AI, so we usually think that, I don't know, because I talk to young people and they are very keen about AI. And I want you to think about AI. What do you think about? What is AI actually? Because you usually want to think about things like objects. Of course, when you talk about eye-driven robotics, it's easier to understand. But when we talk about algorithms, what is in there? And I think that is what is fascinating. And what is interesting is that FDA actually made sure that they are starting to have a website on the FDA to show the upcoming algorithms being used in healthcare. What they want to do is that to make it very transparent, that you know which type of data is included in that kind of an algorithm. It's very interesting because I think that's where we need to go. We need to have the openness around the AI to understand what is there, because even the health professionals, if you go into the surgery room, because we have a lot of AI solutions embedded in those technologies. So most of the physicians don't know what is exactly going on there. And I think we need to have that openness around that to expose what is going on within these different kinds of AI algorithms. But it's important to understand that there are, at least for today, there are about 4 many types of AI algorithm. There is a supervised learning where you can go back and change things. There is unsupervised learning, and I think that's where we need to be careful because you don't know what will come out later when you have the algorithm using a certain data and it's going to start to make its own things based on that data, which could be biased and which could be less representative. And then we have the both supervised and unsupervised data machine learning, which could be actually really interesting to see if you do those 2 mixed models. And then, of course, there is a reinforcement learning that you have to put in the human factor using the data which is there. I think we need to understand those things. What is happening now, all countries, because this is also becoming the new gold with AI and data, and which algorithms are being used in different segments in society, not only healthcare, it's in finance, it's in logistics, it's in different things. So we need to be aware of that. And Sweden, of course, wants to be the best when it comes to the AI development and innovations. China has just launched their own strategy on AI. US is doing that. UK, many other countries are doing that. And I think which is an incredible time we are living in. But from the research side, of course, we need to follow this very closely to understand the effects and also the barriers and risks and biases that could be related to that, because it can be corrected. So when we go back to the devices, and the Norwegian colleague talked about the telemedicine, the home monitoring. So we have a lot of medical devices being used in monitoring, in diagnostics, in connections with our healthcare professionals, triage, leading to treatments, and some of them are AI driven. Okay. And then we need to understand within those medical devices, so you have sensors, and some, I believe many of you have these beautiful smartwatches. It's collecting a lot of data on different things, on your oxygen level, on your temperature, on blood pressure, on heart rate variability, all those things. But the technology behind that, behind the sensors, is being developed a lot. And many of them are AI driven, of course. But there is a technology which is called PPG, it's called the photomomography technology, which is behind many sensors, which means that these are non-invasive, because you wonder how can a smartwatch measure my blood pressure? Because, you know, the traditional ways of measuring blood pressure are different. So this is non-invasive. What it does, because the sensor has this PPG technology, which makes photos actually within between your skin, and then get different kinds of data going on. Then you get your blood pressure showing up on your smartphone, right? But that technology is being actually, there are a lot of publications coming up now showing that we need to understand the sensitivity of the data and the accuracy of the data, because it has shown that it could be sensitive to temperatures, could be sensitive to noises, could be, and there is another one which is related actually through the digital divide and the inequalities that could come up, that depending on the tone of the skin color, you may get different measurements, because when the device starts to get the photos from your skin color, from your skin, depending on the color of your skin, it may make inaccurate measurements. So we need to be careful about which data is being used. And that's the data that will be put into different kinds of algorithms. And as you know that many of the big tech companies like Apple, Google, Amazon, they are using that kind of data to create, and they have algorithms creating this, beautiful curves afterwards, which come out with heart rate variability when you go to your doctor. Then it could be combined with another kinds of algorithms. So I just wanted to deep dive here a little bit into what kinds of algorithms are we talking about, and how do they come up? And of course, it's about programming, but also, of course, the data coming in and which kinds of data is being used. And we need to think about, I remember my friend, Dr. Roy, is fascinated about our Swedish data registries. It's beautiful. We have a lot of data here. So we need to look into that data if we are going to use AI to use the registries. So we need also to understand how representative they are. Are they representing all groups in society, the elderly, the minorities, people with low education, all those things? So we need to think about that. And of course, the registries we have in Sweden, so we have a person identifier number, which is helps it to connect. If you go to the doctor, then it will be connected. Now we have other digital platforms like the 1177, where everything is being put in there. So in terms of getting data using AI, I think there is good actually infrastructure to be able to do that. So the next thing would be to really demonstrate evidence-based, which we call real-world evidence, to show the effects and also the risks and barriers and challenges that need to be revised. I'm gonna make some few just to conclude here. I would like to. I talked about the evidence, but I want to talk about the implementation part. So this is where we find it interesting for us who are doing research in this area, because before you used to think about, and of course, health systems look different around the world. In the Nordic countries, you find that healthcare is being financed by taxation revenues. So which means we have a mixed model of the public sector deliveries and the private sector, right? So we have that. But so which means that if we are going to buy new technologies being used in healthcare, so we must have, especially for those who are public providers, they need to have the public procurement process. So what we have seen that before implementing the technologies, including AI algorithms, so the procurement process needs to be addressed, because if we don't know which health outcomes we want to target with those new digital health technologies, and how we are going to deal with variations in different groups, different categories, then the implementation won't be successful. Because if we don't have those categories already addressed in the procurement process, so we are going to get a technology that won't be able to address what we thought we wanted to do, but we had intentions, but they were not well elaborated. So procurement is very important. And of course, we come into the equity and the ethics. It's really very important. Many people are talking about responsible AI. And within the EU, we have the regulations. We have the EU AI regulation. We have the medical device regulation, which is called MDR. And there they say that, and many of the MDRs, the medical devices, they do have AI-driven solutions. So they need to show the evidence before those technologies come to market and after they've come into the market, because they want to understand the real world evidence, what happening in the real world. So we are monitoring very closely the WHO recommendations on ethical AI. I think it's really very important because it touches on the social determinants of health. That's where the equity issues come into play. And then I would like also to talk about the digital health capabilities, like Dr. Chu talked about very well. Digital health literacy is a big issue. Actually, it has been shown now to be a super determinant of health. So with that, we see that we are going to face new forms of inequalities related to AI, related to digitalization, related to all digital health technologies that need to be addressed in national and international policies. So from the research part, we need to provide the evidence that will inform new policies to address the new forms of inequalities being created by digitalization, AI, digital health technologies, where digital health literacy becomes an issue. So I'd like to thank you very much, and I think this is a global movement which you are creating, Dr. Roy and Dr. Edson, and everyone who is here. Thank you very much for this space.
What an insightful sharing, Dr. Sarah, thank you for the presentation. Now we have come to the fourth and the last presenter, Dr. Muhammad Sif Azhar Marikan Abdullah. He's a director from Kajang General Hospital, Ministry of Health, Malaysia. Upon of his postgraduate training from London South Bank University in 2015, Dr. Azhar currently serves as a hospital administrator with the Ministry of Health Malaysia, over 15 years of leading 6 different public hospitals. He has commissioned 2 new IT hospitals and is currently on his 3rd for a women and children clinical block, making every staff and patient excited about it. He is a data-driven and evidence-based in all decision-making, hence bridging the gap between clinicians and administrators. Dr. Azhar also emphasized quality and patient safety in his day-to-day work, admitting him as an accreditation survivor for the Malaysian Society for Quality Health, MSSQH. He also actively conducts research in health management and has published in them in academic journals as well as presentation in the international conferences. He was awarded fellowship in epidemiology and biostatistics by UNSW Australia in 2023, and his action, research, and contribution in putting policy in place to control and manage the hospital through the pandemic. Dr. Azhar received numerous local and international awards from LEED Green Hospital, Ibadah Friendly Hospital, UK Alumni, and AEMAS Energy Management. He was bestowed by many awards from local royalty and His Majesty King Charles III. Dr. Azhar is a traditional archer and spent time with horses to calm the heart and mind. So, for the final presentation, please give a warm welcome to Dr. Muhammad Sif Azhar Marikan Abdullah of Kajang General Hospital, who will be talking on the challenges for digital health literacy for high-risk group in Malaysian public hospital. Over to you.
Thank you, Edison, for the welcoming talk. And I would like to thank the organizers for inviting me, and to all attending the webinar. Thank you for staying till the end, as I'm the last speaker for the day. And if I would be allowed to share my screen, I have a short presentation. I hope to reach Prof. Sarah's level one day to deliver a talk. No, without any presentation slides. Prof. Sarah, if I may. Right. Okay. Let me just get that up. Okay. Right. Okay. I'll be touching on the challenges of digital health literacy for high-risk group patients in the Malaysian public health hospitals. And I'll be covering the following for this evening's presentation, starting with some definition and introduction, and followed by an example of a digital health that was carried out in one Malaysian public hospital, and then probably some discussion points before I end my talk. And there are several key definitions that I would like to share, and this kind of wraps up what Dr. Stephen has presented earlier. The definition on digital literacy, right? Digital literacy is the ability to handle any device, for that matter, computer device, to access information in a digital format, assess its credibility and relevance, and then being able to apply it to a specific context. Whereas health literacy is the social and cognitive competencies that determine a person's level of motivation and ability to assess, understand, and use information in ways that promote and maintain good health. And finally, specifically for this talk, digital health literacy means the ability of individuals to search for, to understand, and to evaluate health information obtained from electronic sources, and to apply the knowledge acquired to address or solve health problems.
Dr. Azhar, could you make it, because your slide is not moving, could you make it a slide presentation mode?
Okay. Presentation. Okay, is it moving?
Oh, it's not up here. Yeah, maybe outside share the screen for you. Is it possible?
Okay.
Possible? Yeah. Okay. I think our team will do the sharing.
Thank you, thank you. Sorry for the trouble. Okay, I think we move on to the third slide, please. Okay, right. So this was the definitions that I mentioned earlier. We can move on to the next slide. Okay, digital health technology, as Prof. Sarah mentioned earlier, I mean, according to the US FDA, the FDA defines digital health technology as the broad scope of categories that involve electronic health records. You have virtual visits, you have wearable technology, digital therapeutics, AI, telemedicine, and machine learning. Now, in health literacy, we have seen that patients have moved from searching and receiving health information from their healthcare providers, mainstream media and hard copy education materials, to electronic via the internet using various devices. This online health information seeking behavior is also observed in low to middle income countries, including Malaysia. Digital health literacy has also promoted the provision of health services and also improving self-care and health outcomes. However, during implementation, local challenges were observed in the Malaysian public hospitals. Next slide, please. This slide is to share a telehealth project that was undertaken last year in one of our new cardiac centers in the Klang Valley. This was a basic application that was created by the cardiology department to cater for cardiac patients. And the objective was to allow some form of teleconsultation and to also have some